joining us. I'm going to share my screen. Really bad at some of this stuff. Okay, can you guys see my PowerPoint?
Looks great.
Do you see it as the audience should see it? No.
There you go.
Then you're going to see it weird up there. You guys are okay with that? Okay. It's weird. I can hear myself. Okay, so I know not all of you know me, but some of you do. It's nice to see some familiar faces. So I'll do a brief introduction just so you guys can all understand where I'm coming from. So my name is Erica Brandt. I'm currently the hospital director at the Meridian location. But in my heart, I am an ECC technician. I have worked with this group for 22 years. So when I started working with this location and with this group, we were actually called AERCI, or the Animal Emergency and Referral Center of Idaho, which became West Vet. And so for 22 years, I've kind of followed this group around and been through the various changes. I started as a CVT a couple of years out of school and got my VTS in 2009 while I was working with the group. And I guess I stuck around long enough that they made me a hospital director. So now I'm at Meridian. One of my biggest passions, I guess, is teching and my tech group. The one thing that I would probably say about me is that I do have 22 years of knowledge. And honestly, if I could put it in a box and put a bow on it and give it to everyone that I meet, I would love to share it, because this profession can be challenging at times. And the way that we learn this information and gather this information is very difficult. But what you'll notice is I have 48 slides, which is way too much for tonight. And I want to tell you all of it in one evening, which we won't get through. But my email is here. I'm always available. I know Lindsay has one of my presentations for triage and patient care and those kind of things. But if you guys are ever have questions or want training, please let me know. Brookie knows that I'm pretty passionate about this stuff too. I'm a national speaker and speak all over the world. I just want technicians to have good information and feel great and become amazing at what they do and just really love taking care of patients. Like I said, I've been in the profession a really long time, and so I've hired a lot of technicians. I've fired a lot of technicians, unfortunately. I've trained a lot of technicians. I've seen a lot of people come and go. And I always struggled a little bit with what is it that really makes a good technician, and what do I need to train you guys to make you confident and secure in what you're doing. And I fortunately had a lot of opportunities in my career, probably because I stuck around for so long and they couldn't get rid of me. But one of the things that I got to do was I worked with a group called American Association of Feline Practitioners, which now just changed their name to Feline VMA. If you like kitties or you're interested in taking care of cats, definitely would highly recommend them. But I got to go and work with them on their nursing care guidelines that are actually published now. They're really great guidelines, but the first paragraph, this is the first paragraph from that document, it talked about the science and the art of veterinary medicine. And it really changed the way I thought about what I teach and what I do and what really makes a great technician. We all get so wrapped up and so focused in, I'm going to be an advanced technician if, or I'm going to be a great technician if I can do this specific task. And it's usually something around like central lines or feeding tubes or some like big advanced skill that we all think is really important. And what I have learned through my career is the most important thing that we can have is thinking about our patients individually, what our patient needs from us, and really critically thinking about patients. So this is my favorite presentation. I give it all over the US. And it's really based on why patient care is important and critical thinking. So we're not going to talk about how to place a central line standing on your head. We're not going to talk about how to be the best technician doing CPR. We're really just going to talk about thinking about your patient and different tips and tricks that I have learned taking care of patients in my 20 years in the hospital. Patient care is a wide scope. The definition of patient care could be pretty elaborate. Really what patient care is anything that we do for that patient to make them feel better. And it also is anything that we do while we're caring for this patient to alert the team that something has changed. So the biggest reason why patient care is so important is because recognizing those emergencies, which you guys know, is life changing for these pets sometimes. So knowing when they come in and they start decompensating, knowing when they're in the hospital and they start decompensating, knowing when the client is in the exam room and they don't know what's going on and the pet starts decompensating. So recognizing an emergency saves lives of so many patients. And this is that technician that just kind of knows and starts setting up the crash station or just knows that something different is happening with their patient. And these are the technicians that everyone really sees as they're very skilled, they're very knowledgeable. And I'm going to tell you the things that we watch for as those technicians. One thing about really good patient care is it also allows the doctors to be efficient. We can see more patients, we can take care of more patients, we can talk to more clients if the technicians have really good patient care and if they're really critically thinking about their cases. It's the difference between the patient surviving and the patient thriving, because our ultimate goal is that they get to leave the hospital. And the better patient care we have in the hospital, the more we're watching and adjusting to changes in that patient, the faster that they get to leave the hospital. And then we can respond appropriately to the changes that patient has. We are advocates for our patients. If we are good at critically thinking, if we're good at patient care, it increases our job satisfaction, right? Like you guys want to feel like part of the team. You don't want to feel like you're someone coming in just writing down vitals and relaying them to the doctor. Like we are important. We look at that patient, we communicate, we discuss, we think about what's going on with that patient at all times. It increases the quality of patient care. So if the only person in the room who is thinking about that patient's plan and who is making adjustments is the doctor, the patient care for that patient actually decompensates, right? If all of us, anybody who comes in contact with that patient from the front desk to the back is like, how is this patient doing? Is there something I should be doing differently? What does this patient need from me? It increases the quality of patient care and increases our teamwork. So critical thinking, it has to be about the patient and not necessarily about the task. And I know that we all know this and it seems really silly, but I can tell you 22 years of evolving how we schedule patient care, how we do patient care. I see the same problems over and over again. And Brooke is going to laugh, but when I first started in the building next door at AERCI, we had a paper sheet on the doctor's desk. And it was just one big paper sheet, and that's what we did our treatments off of. And it had times, and it had treatments, and it had the patients listed. And what I would watch technicians do is they would say, okay, it's 6 o'clock. They would walk past all of the patients and to the treatment sheet on the counter and be like, who has 6 o'clock treatments? And they would go to that patient. That's not necessarily wrong, right? That patient was due, that's that patient we went to. And then we evolved to sheets on the cage. So everyone had their own individual sheet. We had little sheets in the beginning, and then they morphed into this like 3-page trifold thing that got really crazy. And it took us 4 hours to highlight the thing when we came in for the new shift. And I would still watch technicians, oh, it's 6 o'clock, walk past all of their patients and go to the only patient that was due during that hour. And so we missed a lot of things. We missed a lot of things because if a patient wasn't due and we weren't going and just going in the cage and doing vitals and checking the boxes, we were doing laundry, we were socializing, we were doing whatever technicians do when they're not doing treatments, and we missed some things. And so it has evolved. And then we got software and we started what I call managing the software, not managing the patients. And so we will sit at the desk and look at the treatments that pop up, and we complete those treatments and not necessarily go and look at that patient and go to that patient and see what that patient needs per patient. We'll talk about that. So no matter what software we have, no matter what treatments we have, no matter how things are scheduled, a lot of times technicians will get in this mode of the patient care is a task that is scheduled for me, and I only do the things that are indicated on the check boxes, and I'm doing it to complete the task. And so I have really tried in my career, as I advance my patient care, is to think about each patient as an individual patient. And I'll give you an example. When someone gives me rounds, if they approach me as this is a hemoabdomen, it's a typical hemoabdomen, or I hear this a lot with TPLOs, this is a typical TPLO patient. I will stop and say, what is his name? Because in my brain, if that's a TPLO and I'm taking care of a TPLO, that's a very generic task-oriented thing for me. But I want to know that his name is Ruger and he isn't used to being in a kennel and he has some separation anxiety. He's not used to walking on a leash because his dad lets him do whatever he wants, and he's a German short hair pointer and he's kind of weird anyway. You know, those types of things is what I want to start thinking about for that patient. So he might need a little bit longer leash. He might need to get out of his cage a little more often. He might be a little bit crazy when I sling walk him outside and I need to grab Lindsay to help me. So I automatically start thinking about who this patient is as a patient and what it needs from me, and not just that it's a TPLO. And so that helps me stay focused on the patient and not the tasks, I guess. So critical thinking is a skill that we have to develop. It's just like learning how to place catheters and those types of things. We have to remember to practice it and to keep ourselves in the flow of doing it. It's hard not to get focused in this job of just getting things done and moving on. And so that really helps keep me focused on what the patient needs. So I'm going to talk to you guys tonight about the nursing process. I pulled this out of human medicine when I was going through and trying to develop my approach to this, because in human medicine, we teach human nurses how to be more autonomous and how to actually make plans for their patients. And in tech school, I can tell you that no one talked to me about making a plan for my patient. They talked to me more about following the directions that were put down by the doctor. And so what I want to talk to you about is more making your plan as a technician, not stepping outside the bounds of what we should be doing as technicians, but thinking about that patient and what I should be doing for them. And a lot of this will you'll understand more as we talk about it. But in human nursing, they teach them a cycle called the human nursing or the nursing process. And it starts with the assessment or evaluation of the patient. So physical exam and emotional needs of the patient, which is a little bit harder for us to do with animals, but recognizing, is this patient comfortable? Are they anxious? Do they have concerns? Can I address those concerns? And we can do some of that with our animal patients. And then they actually talk about a nursing diagnosis, which I am a little bit nervous about talking about a diagnosis because technicians shouldn't be diagnosing. So I call it the technician conclusion. And what this is, if you read about it in human nursing as well, is it's taking all of those things we know about this patient and making a decision as far as what is this patient going to need from me tonight. So what is our goal? I need to get this TPLO eating on its oral meds so it can go home. That is my diagnosis. This is a really big dog. He's down. I'm going to need some help with him. So gathering all of the information we know about this patient and really deciding what my concerns are, what the patient's concerns are, and how I'm going to address those. So the expectations of the patient and the anticipated needs of the patient go underneath this technician conclusion. And then planning, how am I going to get ready? How am I going to structure my treatments? If I have 10 patients, how am I going to organize their treatments efficiently? So I'm not giving medications to this one and doing vitals on this one and going back to this one and then taking it for a walk and then going back to this one. But how am I going to organize everything so I can touch every patient efficiently and make sure I'm taking care of each patient and not feeling rushed or just completing the tasks. So getting ready, discussing with the team what my concerns are, discussing with the team if I have any concerns about, I have 10 patients, these two are pretty critical, I might need some help, those types of things. Implementation, this is what technicians are used to doing. So when we talk about treatments, you guys are gonna be like, this is what I do. This is what we're taught to do. This is what we're comfortable with. This is really what we think about when we think about what technicians do, is the implementation part of it. And then the other thing I want to talk to you guys about is the reevaluation. When you approach that patient, when you go in and start doing those vitals, what has changed in this patient? Is it for the better or the worse, or for the worse? And should we be doing something about it? So those are the things that we're going to talk about tonight. So the first thing with assessment, I always approach a patient with what are the goals for this patient and what does this patient need from me? The way that we get an assessment or we understand what's going on with the patient is we get a history. Why is this patient here? You guys might get the history from the client. You might get the history from the doctor, you might get the history from other technicians, but we are getting some form of history on why this patient is here today, not what happened to it 2 years ago when it was in a litter of 6 and grew up on a farm and all of these things. But why is this patient here right now? We need to get efficient and sufficient rounds. Rounds are very important. We'll talk about that. You might have to review the record, right? Look through the record, see why they were seen last week, see if there's anything we missed in rounds, because we're humans and sometimes that happens. What are the current treatments? So what are we doing to take care of this patient right now? And do I think there's any areas where we could kind of improve that? Completing a physical exam. So I'm going to talk to you guys about a rapid assessment versus a TPR. And then we'll also talk about, several times I will mention, technicians should be doing a full physical exam. If you go into that kennel and just do vitals, you are going to miss some things. So doing your full physical exam, looking at their eyes, touching their ears, looking at them. Are their feet fat? Do they have lumps that they didn't have before? Is there petechiation? Like all of these things that are not in one of those boxes, temperature, pulse, respiration. So actually taking a look at the patient. And then expectations. Has anything changed when I approach this patient? Is he in the back of the cage now and not paying attention to me when earlier he was wagging his tail and happy to see me? Is this kitty lateral and purring now? Is this patient really anxious now when he was sleeping earlier? You know, has something changed mentation wise? Is his temperature up by 0.5 degree? And am I concerned about that? So what are the changes, and then what are the goals? Why are we here? What are we doing? What are our expectations for this patient, and are they following what our expectations are? And then kind of anticipating those needs. And you guys do this when you are like, I'm setting up a crash station. I'm going to have an intratracheal tube right here. I'm going to get gloves ready because this dog's gonna poop all over its bed. Like whatever it is, you guys are doing those things. So the assessment and conclusion definitely go together. So gathering the information, deciding what my plan is going to be, making that planning happening, discussing with the team if we need to. Implementation is our treatments, whether it's us or the doctor or another team. And then evaluation is all of this working. Have you guys ever had a miscommunication?
Once or twice, yeah.
Have you ever had a miscommunication during rounds?
Yes.
Yes. So rounds are very important. It's also very important that we communicate in a way that is efficient and sufficient, and we are getting everything that we need about that patient. I think rounds are very important because you just spent the last 12 hours with that patient. So do I want to come in ground zero and not know that this patient does not like wet food, it only eats kibble, and it only eats kibble out of the pink bowl, and it only pees on the right side of the yard? I don't want to have to come in and figure all that stuff out about this patient again, right? Because then we're back at square one. Then the patient's not peeing outside, he's not eating again, he is trying to kill me when I'm trying to give him his oral meds when Lindsay already knew that. You know what I mean? There's so much information that we need to have to keep moving forward. And the only, and this might ruffle some feathers, but I'm going to say it, the only real reason for not giving rounds or getting rounds or being a jerk during rounds is ego. It is never about the patient. If you do not want to get good rounds, if you do not want to give good rounds, that is you. That is never in the best interest of the patient. That is always ego. There are a lot of things around patient care that have a lot to do with ego. Not asking questions, not asking for help, and rounds is one of them. So if you are one of these people, or you find yourself saying, I am not going to do rounds, I don't want rounds, I don't need rounds, you really need to look at yourself and say, do I have my patient's best interest in mind? So why are rounds important? Make sure everyone has the same information, right? What are the client's expectations? What does this patient need from us? What did the doctor 2 shifts ago tell us? Like, what do we need to know? And it makes for good teamwork and good efficiency. We have to be able to talk to each other about patients and share information. There are terrible mistakes that happen that can be avoided just by us talking to each other. Less investigation, less problem solving by the next team. If I spend all 12 hours trying to figure out what this patient needs again, we are behind, right? Can you imagine if the doctors didn't talk to each other and they were like, I wonder what's going on with this patient. Let me do a physical exam and let me redo the blood work. We have to talk to each other. The quality of nursing care largely depends on the nurse understanding what the patient needs. And if we can tell each other, this is what we're doing with this patient, you're already on the right track. Oh, yep. We have to train. We have to remember this stuff. Sometimes this stuff doesn't last. If you are like, man, our rounds are awful right now, maybe we should have some training on rounds, right? Maybe we should have some training on patient care. Maybe we should have some training on fluid therapy, you know. That's why Brookie is here. You guys are so lucky to have her. So why do rounds go bad? One of the number one reasons why rounds go bad is because we all get a little bit caught up in our own bubble, and we have a little bit of an ego issue sometimes. Poor communication. If you are a poor communicator, or if you are getting rounds from someone who's a poor communicator, talk about it. Say, I have no idea what you just said to me. Or say, hey, can you explain that? Or how did we get here? Sometimes rounds are bad because we give information that is not pertinent, right? So for example, if I came up to you and said, oh, I have this parvo case and my mom is such a bee and I have to work with her all day and she keeps calling and blah, blah, blah. You know, I'm probably going to say to you, I'm really sorry that happened. Can you tell me about the patient? And it's not because I'm being a jerk. It's because after I talk to you about for 15 minutes about what a jerk the mom is, then we don't talk about the patient, right? And I want to make sure you get home and have a good quality of life and all of those types of things, but try to make sure our rounds are standard. We're being respectful of each other's time, and we're really talking about things that are important. The other thing that's really hard is maybe mom isn't a bee and she just needed a nap and a cookie and she's going to come back on my shift and she's going to be fine. But if I'm already mad at her because she was mean to my friend Lindsay, then we have a problem. So trying to keep just really facts, not feelings, right? Just really focus on the patient. Distractions, complicated cases, lack of legibility of medical records. Luckily, we don't have that as much anymore. But there used to be times where we were like, what is this treatment? What does this say?
Particularly your husband's handwriting.
Exactly. Incomplete records or rounds, right? This is just a typical TPLO, and then you find out later that it has whatever going on. And you're like, whoa, I didn't know that. This was a typical TPLO. For me, a typical TPLO might be different than your typical TPO. Varying degrees of knowledge. You might be rattling off something about DKA patients, and I'm like, I have no idea what you just said, hyperosmolar or whatever, and I don't understand. Make sure that we are creating an area that's safe for you to say, I have no idea what that word means. Would you mind sharing with me what I'm truly watching for in this patient? And be okay with that. Like, that's another ego thing where I want you to take really good care of my patient. And so I would rather have you say, I don't know what it means when you say we need to do this TID. Like, what is TID? And I know you guys all know that, but if you don't know that, and then you spend all night going, I don't know what TID is. Like, make sure we're talking about it. Disrespect, crazy times, exhausted staff. There's a lot of reasons why rounds go wrong, but they are so, so important. And we really have to take our egos out of it and really think about the patient. So different techniques. We do group rounds, we do one-on-one rounds, we do cage side rounds, we do in front of the patient, we do away from the patient. We do printed forms, we do casual notes. Sometimes people write stuff down and they give it to us and we have to read it ourselves. Really, the thing that we need to understand is what works for you. So if you're like, I would rather do rounds while we're looking at the patient, or I need to step away because things are too crazy right now and I can't focus on you. Just be verbal about what you need and what kind of works for the team. If you guys start recognizing our rounds are terrible and we're not doing very good, like get a group together and decide what we need to do. So the percentage on there are how often or what kind of rounds we're typically doing. And this is based on human medicine. And then also we see more mistakes with rounds that are only verbal. So only telling you what your 25 patients need for the night, you might not retain all of that. But if I tell you verbally, if we walk through and look at all the patients and I have it written down, you are going to have more of a success rate on what we're passing on. Okay, so when we think about assessing patients, so we've gone through the medical record, we've gotten good rounds. Now we're going to go look at our patient. When I think about assessing an emergency, I always think of triage, right? So first off, triage, and we're going to talk about patients coming into the hospital and we're going to talk about patients already in the hospital. But when you guys triage, this is the first step to a successful emergency, to recognizing an emergency. We have to think about, what is this patient trying to tell me? Is it breathing funny? Is it laying down? Is it limping? Is it not mentally appropriate? Is it urinating in the lobby? Like, what is this patient doing that makes me recognize something bad is happening? And then what is the owner telling you? Owners are crazy and they will come at you with a diagnosis, right? And sometimes it's completely wrong. Like, all cats that are blocked are constipated. Like the owner, right? And they're 99% of the time they are not constipated. They have a urinary issue. And so, but we need to be able to recognize what the owner is trying to turn into a diagnosis and really focus on the symptoms, but always be cautious when facing a potential emergency. Sometimes the owner saw something at home and the dog was like excited about the car ride and they look better when they get here. And then you put them in a room. I put a bloat in a room. I didn't get fired, so here we are. But I have done that where the patient looks okay up front, the owner's giving me weird symptoms, and I'm like, I have no idea what's going on. I go in, get vitals, the vitals are somewhat normal, and then the doctor goes in and says, this dog is bloated. Like, what are you thinking? So always be cautious, always make sure we're watching these patients and doing a rapid assessment and having good discussions if you're concerned. So gathering an assessment for patients in the hospital. So it's already hospitalized, it's already in our care. How do we gather some of this information? So, and this can happen in the room too, or even up front. But one of the first things that I try to do, and I have studied this for so long and taught this for so long, I do this everywhere. I come to your house for dinner, I'm assessing your patients. I'm out on the foothills, someone walks by with their dog, I'm assessing their patient. Like, any cage that I walk by, whether I'm in the hospital for a meeting or I'm actually taking care of patients, every cage that I walk by, I'm looking at that patient and deciding, are they going to live for a few more minutes or do I need to say something? Because it is hardwired in my brain right now. But observing from a distance, we actually have documented studies for pain control, mostly on patients where they showed signs of pain on the camera in a room by themselves. And as soon as humans walked in, they got up, they wagged their tail, they were more interactive because of that human interaction. So if you approach a patient in a room or you approach a patient in the hospital and they see you coming for them, their heart rate and their respiratory rate can change, and also their mental status. And so what I try to do, if I'm in a room with a client, I'm talking to the client and getting the history and I'm counting the respiratory rate and I'm looking at that patient's mental status. If I go to do vitals on a patient or I'm observing my patient, I try to watch them without approaching the door or approaching the cage. So I already have a respiratory rate and that patient's mental status somewhat in my brain before I even open the cage door. So a lot of our observation, a lot of some of our assessment should happen before that patient knows that you're even looking at them. And then make sure you are doing a complete physical exam. If you are only doing a TPR, if you're only doing respiration alertness perfusion, which is what I'm going to teach you, you are doing your patient a disservice. You are doing yourself a disservice because you're going to miss something. So for example, if you are monitoring a patient all night long and all of a sudden they develop petechia on their abdomen, you're not going to notice it if you're only doing vitals. If the patient develops fat foot and then the next shift comes in and Lindsay says, this Erica girl is awful, this patient probably had fat foot all night and she never noticed it. If I'm only doing TPR, I might not notice that the patient has a fat foot. So making sure you're doing a complete physical exam. And then vitals, not only know what textbook normals are, but know what's normal for your patient. So for example, a normal temperature in a dog is 101.5. We don't consider it a fever or a concern if it's between 99 and 103, right? That's a pretty safe zone. However, if you have a patient who has a foreign body that we're trying to get it to pass and it's on fluids and its temperature has been 100.2 for the last 24 hours, and now I go in there and it's 101.5, that patient's temperature is normal. However, I have a patient who has a concern for perfing or becoming septic that just increased its body temperature by 1.3 degrees. Is it normal for that patient? I'm concerned now, right? So I'm going to check it instead of 4 hours later when it's up to 105, hopefully not. But I'm going to check it within an hour and I'm going to let my doctor know, hey, we had a pretty significant increase in temperature. Just to let you know, I'm going to keep an eye on it and take another temperature in an hour. Make sure you understand trends. Normal, 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 not normal. In my professional experience of 20 years, there have been very, very few and rare cases where a patient was absolutely 100% normal and perfect and died the next second, right? There's always an indication, there's always a sign that heart rate is dropping, agitation is increasing, mentation is decreasing before that patient arrests, and that happens with anesthesia as well. And that's why anesthesia sheets, why we monitor anesthesia, because we're looking for that trend. Is everything normal, 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 or is it declining, or is it increasing and the patient's going to wake up? Like, watch your trends and understand your trends. Additional things that we want to assess right away: anxiety and pain, agitation, and what this patient's actual behavior is. Typically, you guys can pick up on it in the room. If the owner says, oh my gosh, I can't believe she let you do that, you're like, this patient is sick, right? So, all right, so I'm going to teach you what I do versus TPR. TPR is a great temperature, pulse, respiration on normal, healthy patients. When I look at a patient and I want a very quick assessment, I do what's called RAP. So respiration, alertness, and perfusion. Those are the three things that are going to tell me if you're going to die quickly or if I have a few minutes. And so when I'm triaging patients up front, when I first approach my patient in the hospital, I am looking at their respiration, alertness, and perfusion just to see what this patient's critical status is. So the first thing I'm looking at is respiration. Respiratory rate is difficult, especially in dogs, because dogs pant when they're happy, dogs pant when they're distressed. Like, increased respiratory rates don't tell me a ton of information. If you look at respiratory rates, it all kind of depends on if the dog is sleeping or what its age is. And really, it kind of goes all out the window when we're meeting a patient for the first time. So what I want you to start looking at is that patient's respiratory effort. Are they completely focused on breathing and not focused on anything else? Does it look like their chest is really working hard to get breaths in? Are they making any weird sounds while they're doing it? Do they have their head back and they're orthopneic? Those types of things. Are they laterally recumbent and they're not acting like I think they would, or breathing really slow and shallow when they should be happy to see me and panting? Alertness, mental status is one of the first indications we get that a patient is shocking. And we talk about this in movies, right? They're like, oh my gosh, she's going into shock when people stop talking and they get kind of lethargic and kind of quiet. We see this with our veterinary patients too. And so if you are in a room with a pet who is young and energetic and rambunctious, and all of a sudden they get really quiet, to the point where you're like, this doesn't seem normal. Any pets that are carried in, anything that's lateral. If you're taking care of a patient in the hospital and it was excited and bouncing around at the front of the cage and being obnoxious, and now all of a sudden it's in the back of the cage and not really interacting with you, you have to make a mental note something has changes in that patient's mental alertness. Perfusion, mucous membrane color, and CRT. Absolutely, we're checking that up front. I feel like every patient that I check this up front seems a little bit pale, but maybe that's just me being paranoid. Mucous membrane and CRT, fill pulses. So if you guys don't die trying to fill a pulse up front by yourself, but I feel for pulses right away. So I'm feeling for pulses before I'm listening to the patient sometimes at the same time, but I'm constantly feeling for pulses. Heart rate is another one of those things. It's hard to assess from across the room. Like I can't tell what your heart rate is, even though I can count your respiratory rate, but feeling heart rate, they're going to be a little more excited when they come in probably, and their heart rate's going to be a little bit elevated, but we'll talk about what's normal and what's not normal. And then auscultation. If you are not using a stethoscope, start using a stethoscope. Listening to that patient's heart rate, listening to that patient's lungs, listen to every single patient, because one thing that's really hard that technicians try to do is they try to only learn things when it's abnormal. So learning new drugs, we're like, oh my gosh, this is a big scary anesthesia case and it has cardiac disease and it has whatever going on. I'm going to use this new drug that I never used. And I'm really uncomfortable, but it's supposed to be better for this type of case. Or we're like, well, this patient has an arrhythmia and I've never listened to a dog's chest in my life, but I'm going to try to listen to this one. So listen to normal patients. Do use medications on normal patients. Get used to certain equipment on normal patients. It will always help when you have something abnormal. So normal respiration. So let's talk a little bit more about RAP. So respiration, normal respiration. The observation of a patient breathing assures everyone that the animal has not died, but it does not provide any information on the effectiveness of the breath. So what that means is just because that patient is breathing, it doesn't mean that it has good oxygen saturation, right? And so what we're looking for is, what is its breaths per minute? Does it make any weird noises? And is it working harder to breathe than it should? So this is actually a kitty that came in one night when I was on ER. The CSR up front paged back to me and said, I have a cat who's in labor. And I said, please tell the owners to take it home. Was my first response. Because in my 22 years of veterinary experience, I have seen like 3 cat dystocias. Like cats usually do fine. The owners always bring them in, but they're stressed and they're not they stop their labor and blah, blah, blah. So I'm like, please take it home. So I go up front and assess this cat like a good technician should. And this is what we saw. So this kitty is very orthopnic. It would be easy. So this cat is very pregnant. She's only about a week to 2 weeks due from having her kittens. But this is not a cat in labor. This is a cat in respiratory distress. So she's actually orthopnic. So she is reluctant to lay down. She's keeping her chest off of the bedding. She's very upright, very straight. When she turns around and looks at us, her whiskers are very forward. She has a very concerned face. And look at how fast she's breathing. And nothing scary is happening. Like she's taking very short, choppy breaths because her chest is full of fluid. So this is an FIP kitty who has a chest full of fluid and she can't take big, deep breaths. So she's taking little choppy breaths. She's not in labor. She is in respiratory distress. And I was almost a jerk and missed it, thinking that this cat was in labor, which if I were an owner and didn't know anything about medicine, like, you know, when we see humans giving birth on TV, they always breathe faster. And so it looks like maybe she's going into labor. So we ended up tapping her chest. She did end up having her kittens, but she was an FIP kitty and was truly in respiratory distress. So abnormal breathing effort with an increase in respiratory rate is an absolute emergency. And then also look for that orthopnic positioning. It's a little bit more subtle in cats. It's very hard to pick up, but they're reluctant to lay down and they're always pretty stretched out. And they try to stay as quiet as they can while that's happening. So any questions about assessing respiration really quick? Okay. Mentation. This was another cat that came in on ER when I was working emergency that had got its head shut in a car door. Its vitals were 100% normal. It did not respond to anything. So this was one of the only true comatose patients I've ever seen in my career. Completely total normal vitals, stayed that way overnight, but was not responsive to us at all. Ended up getting an MRI the next day and it had a severed brain stem and we ended up euthanizing. So not very many patients come to us truly comatose and normal. But looking at mentation is very important. If a patient comes into the hospital, they should be somewhat energetic and not lethargic, dumpy, laterally recumbent, anything like that. Those are all patients who are shocky or having a true emergency and should be assessed right away. This was another kitty who came in after getting its little head smashed. I think this might have been like a rocking chair. Cute little baby kitty. That's actually my hand right there.
I recognize the ring.
Yeah, so anisecoria in this kitty. So one pupil is really big and the other one's really small. So an indication that this poor little kitty's brain is not working appropriately. So looking at pupils, abnormal pupil size, pupils that have anisecoria, nystagmus, where they're look like they're watching a tennis match, anything like that should be assessed immediately because it can be an indication that we have some sort of head trauma, which we would want to get assessed right away. The next one is perfusion. So respiration, alertness, perfusion. Perfusion is a little bit harder to look at right away or assess right away. The fastest things you can do is mucous membrane CRT and feeling for pulses. So get used to feeling pulses. Listen to your heart rates, auscultate with the stethoscope. If it is hard to do, if you're trying to do it quickly, you can put your hand on the patient's chest, feel for a heart rate that way, and also feel for pulses at the same time, just to get an assessment. How does this patient look really quickly? Pale, blue, mucous membranes, a heart rate that we consider really slow or bradycardic, or a heart rate that we consider really fast, which we'll talk about what that is, should be assessed pretty quickly. Even if you bring it back and we do, another quick set of vitals, or we let it calm down for a minute and reassess it, it's always best to err on the side of caution and have a second set of eyes on these guys. So besides RAP, the other thing that I look at very quickly and that I sometimes assess from afar is pain, because patients, once they get up and they react to you coming in the room or coming in the cage, it's kind of hard to assess how painful they really are. So looking at their body posture, are they guarded? Are they aggressive now? And the owner says that they've never been aggressive. Is their respiratory rate increased? Are they vocalizing? Do they seem really anxious? And then obtain vitals like heart rate and blood pressure. And this is especially true for patients that are in the hospital. If you approach a doctor and say, I think my patient is painful, they're going to ask you for a few more vitals. They're also going to ask you if they went outside and potty, right? Because anxiety and pain can look somewhat similar in our patients. So before I approach a doctor and say, this dog needs pain medication, I'm going to say, I walked him outside and he pottied. I took his heart rate and his blood pressure and it's a little bit elevated. Nothing that I'm concerned causing crashing, but I think it's an indication that this patient is painful. The other things that we should do is ask ourselves, should this patient be painful? Is pancreatitis painful? Probably. Is a fracture painful? Probably. If you get hit by a car, you get to have pain medication, right? So if something happened to this patient where it should be painful, we should be giving pain medications without looking too far into, is it painful? It is painful. Absolutely. And then anxiety and the need to go potty sometimes look like pain. So make sure we have addressed those things before we ask for pain medication. Cats and pain isn't always easy. So cats are kind of subtle when it comes to pain. If you haven't seen the Grimace scale, please check it out. It's actually very cool. So the facial expressions of cats, where their whiskers are, where their ears are, it's really an amazing cat reading tool because they're pretty quiet. When I first started in GP, before I even came to emergency medicine, I thought all blocked cats were jerks. And now I realize that we just weren't taking care of their pain because those kitties were painful. So most cats will get depressed or aggressive when they're really painful. They don't want to be touched. I don't want to be touched when I'm painful. So I kind of get that. They don't really vocalize. A lot of times they'll purr. They're kind of in a hunched position. They stay in the back of the cage in a low position typically. They don't make eye contact. They don't want to be touched. They don't want to eat. They're very much in the back of the cage. And if they have something going on that might be painful, they're painful. So good drugs of choice for these guys. We're not going to go too much into that. The only thing I want to say is cats can have opioids. It is a good choice for them. And then of course, dysfunction or disability. If you approach a patient and they are bleeding, if you approach a patient and it's laterally recumbent, if you approach a patient and it's having a seizure, that's an emergency, right? And we should be addressing those things right away. Toxicity, arrest, anything like that. Those are the obvious things that we can assess right away. That patient needs to be dealt with, whether it's in the hospital or in a room. So patient care for those patients is, I recognize that this is not something that should be happening, and I need to rally the troops and get the team making this patient feel better as soon as possible. How are we doing on time? Pretty good. Are you guys okay?
Yeah.
Hanging in there? Okay. Any questions in the chat? No. Everybody still there?
Yep.
Okay. All right, so assessment of hospitalized patients, there's a few more things that we can do. I'm not sure that I'm going to do an abdominal palpation up front. I might do an abdominal palpation in the room, but if I am concerned, if somebody brings in a male cat and they are talking to me about symptoms that seem like the cat's going to be blocked, I'm just going to bring it to the back and assess the bladder. I'm probably not going to do it in front of the owner or up front. I might bring the owner to the back and do it in front of them. Hospitalized patients, we need to be checking catheters and tubes. So anytime you approach that patient, you should be looking at the catheter, feeling the tape, feeling the foot. Is this catheter working appropriately? Is its nasal oxygen line still in? Is its chest tube still in? Whatever it may be, we check those every single time we look at that patient. And then temperature, we don't want to forget about temperature. Temperature is important. However, if you are experiencing an emergency, I'm going to pick it up by respiration alertness perfusion, and the temperature isn't as important in that moment. If I take your temperature and it's high or low, it isn't going to indicate to me that you need treatment sooner or later. You are going to show me by your respiratory rate, alertness, and perfusion first. But temperatures are important. It's important that we take those seriously. Patients that are cold are often shocky or post-op. Patients that are hot are usually we've cooked them in the hospital because they're post-op, or they have some sort of infection, inflammation, or hyperthermia, which we'll talk about treatments a little bit later. Hydration status is not necessarily something that's going to cause that patient to pass away right away. Like, I'm not going to check hydration status and be like, oh, this patient is 10% hydrated, dehydrated, ask them right to the back. But it is something I'm going to look at, whether I'm in the cage, especially if I'm in the cage and the patient is on fluids. I want to check and see, is this patient really jiggly? Does it still seem dehydrated even though we have it on fluids? Those are things I need to be expressing to my team and reassessing this patient's hydration status. And then in the room, I want to assess these things as well. Appetite, is my patient eating? Does it want to eat? Does it not want to eat? Is it ravenous? What's going on that way? Urination and defecation are very important, not only because this is the single most asked about thing by the client, but it is also very important to the patient. Are they urinating? Are they defecating? Because they need to be able to do those things on their own before we can get them home. And there are things that we should be watching. If we haven't noticed that our patient has urinated in 12 hours, that's a problem, right? And sometimes when we're very task oriented, we're like walking the dog outside. It didn't urinate or defecate. We bring it back in and we hook it back up, and it never dawns on us. We didn't judge the last time this dog peed. Does he have a huge giant bladder and he's holding it, or is he not producing urine, which is a 911, right? So making sure that we're making that mental note, and then assessing pain, even if the patient is on pain medication. So this is something that I see happening in the hospital where we have the patient on a treatment and we no longer think about that symptom, right? We have it on a fentanyl CRI, so we no longer say, I think this pet is still painful, right? And it's something we should be thinking about. And I have an orthopnic patient that I'm going to show you later, and we'll talk about that as well. Okay, so now we have done our rounds. We know all the information about this patient and why it's here. We did a quick assessment. So RAP, maybe did a few other things just to quickly assess, is it going to live? Is it going to die? What do I need to do? And now we make our conclusion. So is this patient stable? Is this patient not stable? What are my next steps? So we are going to identify problems or concerns associated with this pet's diagnosis and its current state. Now that I understand its current state, is it comfortable? Is it in a comfortable bed? Is it clean and dry? Is it painful? Is it anxious in its environment? Is there something I can do to make it more comfortable? Is it anorexic and not eating? Do we need to add medication to that? Or do I need to just go a little bit slower with the food? Is this patient having vomiting and diarrhea? And there's a lot of things associated with that. Does it have vomiting and diarrhea? And we need to help treat that so that patient can feel better and go home. Does this patient have vomiting and diarrhea? And I might need to take it out, right? Because if I only have vitals scheduled every 4 hours and this thing is pooping the bed constantly, I'm going to have to check on it more often. And that's a conclusion that I make as a technician, because do I need the doctor to tell me you should be checking this patient more often if it's pooping its pants? No, we should just know, right? So is it vomiting in its bed and I need to check it more often? Am I concerned about regurg versus true vomiting? All of that type of stuff. Is this patient very anxious? Does it hate being in the kennel? Is it anxious around other pets? Can I move it to another kennel? Can I cover its cage? Is it sleeping in the litter box? What can I do to decrease this pet's anxiety? I read a study kind of early in my career too about cats, and there was a gentleman who was a virologist and studied feline viral diseases, and he would go into animal shelters and he would change two things. He would give them a higher quality of food and he would give them a place to hide, and it decreased the viral outbreaks in cats in shelter situations by like 80%. And so for me, that said, the anxiety that is caused by patients in the hospital could potentially keep them sick longer, right? If they're not eating for you, there are certain check boxes we have to check before we feel comfortable sending that patient home. Eating, and then going outside and going to the bathroom on their own. If they're anxious and they're not feeling well, they don't want to eat, they don't want to go outside and urinate and defecate. And so those are anxiety, those anxiety things actually keep that patient from doing that. So making sure we are covering the cage, putting them in a quieter area, approaching them a little bit softer, any of those types of things to reduce anxiety and stress. Movement, getting these guys outside. So encouraging a dog to go outside. And I know this is awful when you don't have as many people as you'd like to have, and you're trying to take this big giant dog outside and it takes 4 of you, but it's so important to get that patient up and moving. Like if any of you guys have ever been in the hospital or had surgery, what's the first thing that those damn nurses make you do? Get up, right? You're like, I just had surgery. I don't feel like doing this, but getting up, taking a shower, using the restroom, getting up and moving around makes you feel like a human again. And it's the same thing for our patients. So getting them out of the cage, getting them up and walking, getting them outside in the grass, in the fresh air, in the sunshine. Like it's so good for their morale. A lot of times outside of the cage, if you take them outside and walk them before you just throw them in a cage with their food, sometimes if you walk them around a little bit and offer their food and water outside of the cage, they're more likely to eat and drink for you versus putting them in a cage with their food and their water really close to them where they feel kind of cooped up and they don't necessarily want to eat for you. Is this patient shocky? Am I concerned this patient is going to become shocky? Is this a pretty critical case? And I'm worried about cardiovascular concerns. Are we watching telemetry? Is it in oxygen? And I'm worried about respiratory concerns. How often should I be checking the respiratory rate on this patient? Is it getting better? Is it getting worse? Do I need to set up a crash station? So those are all things. What does this patient need from me? And what are our goals for this patient? And what are the expectations? If you approach a patient and you're like, this patient has a urinary catheter, but there's no treatment for me to check that, right? So making sure that you are noticing this patient should have a checkbox for this, and really making sure that those things are included on the treatments. Or this patient had surgery and regurgitated in surgery, but it doesn't have any GI protectants, right? And so do I need to add that? Or if this patient was in surgery and I don't see any pain medications, did they fall off? You know, those types of things. And then making sure your treatments are organized. So this is one thing that I see newer technicians doing, or technicians get really frazzled about. If you look at your patient's treatments and they are due at 7 o'clock for all of their vitals, and then an hour later, they're due for all of their medications, and then they're due for feeding or walk or whatever it may be. You are not going to have time to do that, for one, and you're going to feel frustrated because every single hour you're touching that patient, and then your patient isn't resting, right? Again, if you've been in the hospital as a human and the nurse comes in every single hour and wakes you up, you are exhausted. Are you healing? Is that patient healing? There are some patients, if you try to die, I'm going to be in your cage every hour. That's just part of it. If you are feeling okay, if you are recovering from a surgery, if you are getting better, if you're a Q4 to Q6, somewhat stable, just staying in the hospital case, I'm going to line up your treatments and I'm going to leave you alone. However, it doesn't mean that at 7 o'clock, Lindsay's due for treatments, I'm going to do her treatments, and then I'm not going to look at her again for 4 hours. I'm still going to make the rounds. Is she sleeping comfortably? Has she potted in her cage? Does she need something from me? And I'm still going to keep an eye on her. But lining up your treatments, the other thing that's really important, and this will also frustrate the fellow technicians around you, is what if I go into that cage and then I have this dog and it's crazy and I'm trying to do its vitals and I'm like, Brookie, can you bring me a thermometer cover? Or Brookie, can you throw me that Doppler over there? Like, make sure you have your stuff together. So before you approach that patient, okay, I know that this patient is due for everything. And so I am going to make sure I have my thermometer cover and my stethoscope and my leash so I can do vitals, walk it outside. I'm going to go get all of its medications ready and have them ready, and its food. And I'm going to sit in front of that cage and I'm going to do all of these things without bothering anyone around me or leaving and coming back. Like if you go in and do vitals and you shut the door and you go get the food, make the food, and then you come back and you open the cage and you get the patient out and you feed that patient. And you're like, oh, now he's due for 3 minutes. So you shut the door and you go get more food and a pill pocket. And then you go back to that patient and you give those more minutes. Do you see how inefficient that is versus like, I'm going to take care of this patient now, and I'm going to get all of my stuff that I need to take care of this patient. I'm going to go to the door. I'm going to take care of that patient. I'm going to walk it outside. I'm going to get a weight on the way by and try to remember it. I'm terrible at that. So I was always the technician that had all the stuff written on my hand or in my little notebook, like weight, what it was, because I will always get back to the cage and be like, I forgot what the weight was. And then go back to record all of that. But making sure that you are efficient, it will help that patient rest. It'll help those patients' interactions. You will feel like you have more time with that pet, and then you will feel more completed when you get done. If you're running back and forth between patients, between treatments, you will never feel like you are settled in what you're doing. So make sure you're very organized. Planning and implementation. So planning is not just for doctors. I know doctors make our treatment sheets. The doctors make our treatment plan. There are treatments that you guys should be doing that are just understood, right? Like you don't need the doctor to tell you when that patient urinates in the litter box, you got to change the litter box. You don't need the doctor to tell you that patient's bed needs to be changed if it soils in the bed. You don't need the doctor to tell you you have to look for fat foot. So making sure that you are making that plan and implementing that plan as a technician and what that patient needs. So doing your full physical exam, looking for fat foot. So one of the examples I have is, and this has been a debate for 22 years, the fluid therapy line on our treatments. It's the same as it's been for 20 years, and I have watched technicians for 22 years say this patient's fluids are good. 20 mils without ever looking at the patient. And I know we're going to say, I don't have time to go to each patient every single hour and make sure all of these fluids are running. So the number one mistake that I see with technicians and patient care is fluid therapy. Either we're giving the fluids to the bed because it became disconnected. The patient is not, the fluids aren't running. Or another issue, the patient has fat foot or the catheter blew, and for 4 hours I didn't look at it. But I've been recording that patient is getting 20 mils an hour of fluids, which is incorrect, right? And so that fluid therapy line means when I say 20 mils an hour and I fill out that box, it means that I looked at that fluid bag and ensured that it's the correct fluids actually going into the patient. The syringe pump is set up at 20 mils an hour. My doctor didn't run by and change it without telling me, and that actual fluid line is hooked to that patient and is getting those fluids appropriately. So making sure that we are actually doing the things that we're doing and that is our plan to do those things. If we have any concerns, if we're like, hey, this dog is on like 200 mils an hour of fluids, he is peeing in his bed every hour, can we slow those down? Or this patient has been post-op for 3 days, his temperatures have been normal, do we really need to be feeding him every 4 hours, right? So do we need to be doing these treatments? Do we need to be doing more treatments? What is our anticipation? Getting prepared for those things? What are our goals? And then making sure we're being efficient with those treatments and with those patients. And then the implementation is actually what we're doing. So why is this part of it important? This part of it is important is because we are watching for any changes for things doing better, changes for things doing worse, celebrating with the team, getting this patient going home, or alerting the team of a decline so we can take action. If it isn't for the treatments and paying very close attention to the treatments, if you go in and only check the boxes and do vitals, you might do vitals on that patient all night and not recognize that they were doing something, right? So we need to make sure we're actually saying, okay, these are the vitals I got. What does it mean to this patient? Most of the time they're going to be okay, but sometimes it's going to be like, oh, I think I should be a little bit worried about that heart rate, or the blood pressure was a little bit different than it was last time. I'm going to keep a closer eye on that. So making sure we're critically thinking about what we're actually writing down. And so what is this patient's normal? So just like the temperature example that I gave, blood pressure is the same way, ECG can be the same way, mentation can be the same way, respiratory rate can be the same way. What is normal for this patient, not just what's normal for a patient. Observation is a continued treatment. So even if my patient is scheduled Q4 hours and I magically got them all lined up, so I truly do not need to interact with that patient for another 4 hours, I still need to be observing them pretty consistently. So when I had or have a big caseload, or I have several patients, I will start at one patient. I try to pick my critical ones first. So we should be triaging our in-house cases first. What patients need me first? What patients are most critical first? What patients do I need to look at first? And I would just go down the row of my patients. I would go and look at them. Are they sleeping? Do they seem comfortable? Do their fluids seem to be running? Those are treatments and observations I should be running without being prompted. And then as I'm with that patient, so if I'm with George and I'm like, okay, George seems to be doing okay. Is he due for anything? Now I'm going to look and see he's actually due for vitals. He's actually due for meds, and I will do those things. But the observing of those patients should be happening at least every hour or as often as we can do, and just going through and continually looking at them instead of saying George is due at 7. I'm not going to look at anybody else except for those patients that are due at 7 o'clock. So start the treatments outside the cage. We already talked about that. Understand the alerts or concerns. What are our concerns with this patient? Are we concerned that they have a foreign body and they might perf and become septic? Is this patient a DKA and we're concerned about their glucose? Is this an IMHA patient and we're worried they might become anemic? And what am I doing to watch for things like that? Is this patient a cat that was blocked and now it's diuresing and it's on a really high level of fluids? And I need to make sure that it isn't getting fluid overload. Like, what are the concerns for this patient and how am I going to assure myself that this patient is doing okay every time I approach the cage? Not all treatments should be scheduled or requested. We already talked about that. When do I alert the doctor? Anytime you have a concern, you should let the doctor know if something changes. And this changes with skill set, right? Like, I am more confident where I know if I get a blood pressure on a patient and it's declined a little bit, if that's the expectation of this patient, or if it's in the range that this patient has been at for a while, I might feel confident not saying anything and doing another one in 30 minutes. So it comes kind of with skill set, but it also comes with the criticalness of the case. If this is a very critical case, every single number that I get that's different, I'm gonna let the doctor know. If this is a stable TPLO case and I walk this patient outside and I get a blood pressure and it's a systolic of 100 instead of 120, we're probably okay to move on. But the biggest thing is knowing, again, take your ego out of it and just saying, hey, this patient's blood pressure changed. I just wanted to let you know if you're not confident that it's okay. PCBs, anything like that. If you're not sure if we need to change the treatments or we need to do something additional for these patients, I would make sure I would let the doctor know. Make sure that when you approach them, you say something like, hey, can I talk to you about George? So they are ready, they're focused on you, and you could say, this is my concern, this is the number that I got. Also, make sure that when you are approaching a doctor or another team member, you have all of the facts. And so approaching a team member, including a doctor, and saying, for example, I think this patient is painful. If that team member has to say, well, did you check this and did you check this and did you check this? And with experience, you will learn what things are important. And so when I approach a doctor now about pain control, I'm like, I just walked him outside. This is what his blood pressure and his heart rate is. This is the symptoms I'm seeing, and this is why I'm concerned. So make sure you have the facts before facts before feelings. Sorry. So I think, make sure that you have the facts behind why you feel that way or why you're thinking that way about your patient. And then make sure you organize your time with that patient. So triaging critical patients first, triaging critical treatments first. So for example, if I am really getting my butt kicked and I have 20 some patients and I'm just running circles and I have a patient who is septic, I know that that patient's antibiotics are probably the most important treatment in the room. And so if I have to let the TPLO sit for an hour while I give this patient his Baytril and Unison or whatever it is that we're giving him, that should be my priority because that patient will truly decompensate and die if it doesn't have its medication versus the TPLO does need to get outside and it should be a priority, but it's not going to become critical and die if I don't get it outside to go potty in the next 30 minutes. So some treatments are very critical. And if you're like, this patient is due for everything, I do not have time to walk it outside and do all of its vitals. It seems somewhat stable, but I want to make sure it gets its pain medication so it doesn't get painful. I might prioritize feeding and giving that patient its pain medication, go take care of the code or whatever it is in the ER that I need to help with, and come back and finish that patient's vitals. So sometimes treatments need to be triaged, treatments need to be prioritized, and sometimes it's the patients. If you have a critical case, that should be the first one that you're checking on before you're checking on the more stable ones. If you have to prioritize, if you're overwhelmed or really busy, try to line up your treatments, try to approach them very efficiently with all of your stuff in your pockets and all ready to go. Make sure you have a leash and all of those things. And then be ready so I don't have to Brooke 20 times and then she hates working with me. So talking about treatments, now I want to move on and talk about specific tips I have for treatments moving on. So now we have assessed our patient. We have drawn our conclusion about what our patient needs from us. We have a plan. We have all of our vitals lined up, and now we just need to execute them. So tips for respiratory patients. These are the scariest patients in the hospital for me. These are the most critical patients in the hospital for me, are the ones that are in respiratory distress or have respiratory concerns. So one of the biggest things is we need to make sure that these patients are receiving oxygen at all times or as quickly and efficiently as they need to get it. And then making sure we're communicating with the doctors and the other team members, because we may need to sedate and intubate this patient before it crashes and dies. So any changes in these patients, I want to make sure that I communicate very quickly. The other thing I have to be very aware of is if I am uncomfortable performing a treatment on this patient because I feel like it's going to die. So for example, x-rays. If you are asked to do x-rays on a patient and you're like, you should say, if you feel this way, you should say, respectfully, I am concerned if I do x-rays on that patient, it is going to die in radiology. Like, you should be able to say that. If you see team members, or if you're like, this patient is due for a temperature, you should ask yourself, will I kill this patient taking a temperature? And I feel like respiratory cases are those cases where I'm like, if I take this patient out of O's, if I try to take a temperature on this patient, if I restrain it in any way, is it going to die? Because sometimes they do. And so they're very scary for me. These patients are always hot. So we should just automatically assume that they are hot, right? If you've ever had a respiratory issue, if you have asthma or whatever, you get hot when you cannot breathe. And so usually their temperature is up. Usually they always feel a little bit better with their temperature decrease. So Snyder units, I always set at like 68 degrees, try to decrease them a little bit. They typically don't need heat support, and sometimes they feel a little bit better with something a little bit cooler. Keep an eye on these patients. This is a patient, I don't want to be out of the room. I want someone watching them, because if they really are struggling to breathe, what happens is these patients get tired and they give up and they stop breathing, and they are very critical. So making sure we're keeping their nose, their mouth, if it's a case that has an endotracheal tube, anything like that, we have to keep those nasal passages clean. We need to keep their mouth open from any mucus or anything like that so they can breathe. So really watching things like that. Let these patients sleep. So if you do get them to the point where we've given them TORB, we've taken care of their whatever cardiovascular event that they're having that's making them be in respiratory distress, let them sleep, because they will be really tired. Patients who have pneumonia or a chest tube, we do need to make sure we're trying to get them moving and walking, because that will help free up the stuff in their lungs, and we'll get better aspirations of their chest tube if it's safe for them. And then making sure they have IV access, because these are the ones that are going to crash and they need to be sedated or drugs for coding or whatever, so you can get them intubated. So this is orthopneic positioning. This is a kitty, kind of the same scenario I showed you with the other kitty that was in the toes that came in a dystocia. So this kitty, it's very subtle signs, but he's very tucked in, but he will not let his chest touch the blanket. He's not very extended in his neck upwards, but he's kind of out a little bit. And then his whiskers are very forward and he's very concerned. So this is an orthopneic kitty, not very easy to pick up on. But this dog, so this was a dog that we had in the hospital, and I think I was mopping or something, and I walked by and I was like, that patient is orthopneic. And everyone was like, he's on oxygen. Duh, he can't be orthopneic if he's on oxygen. So he was on oxygen. He only had one nasal oxygen cannula, and he was there for pneumonia. But if you look at this patient, even though we're treating him, we're taking very good care of him. He has a beautiful nasal oxygen cannula, and he's at 5 liters per minute. He's getting all the O's. We are not meeting his needs, right? He still cannot breathe. So he's very stretched out. He is a good boy. He doesn't want to lay down, but he did lay down because he's a very good boy. boy and he wants to do what his people are telling him to do. So he laid down for us, but look how stretched out he is. Look at how concerned his face is. And then when he does stand up, he's very stretched out and he's just trying really hard to breathe, but not be dramatic because he's a black lab and they don't do that. But he is a very good boy and he's trying to do what he needs to do and do his best for us. But he is absolutely not getting the oxygen he needs. And so by calling that out and not just being like, oh, we're taking care of this patient and he's already getting those and he should be okay, he is not okay. And so he ended up getting a second nasal oxygen cannula and went right to sleep and felt really a lot better. So making sure we are reassessing these patients in the hospital, whether we feel like they're getting treatments for what's going on or not. So pain medication, oxygen therapy, antiemetics, if they're still vomiting, you need to maybe try something else.
I have a question before you move on.
Yes, ma'am.
Bertha would like your advice on how to advocate for your patients when you come across that situation of, I think this patient's gonna die if I take x-rays. When you have a doctor that is not receptive of that and is insistent that those rads be taken down.
The biggest thing I would do is communicate. I feel like this patient is gonna die if I do these x-rays. If the doctor says, I think it's gonna be okay, I would still do x-rays, but I would be very cautious. So oxygen in the x-ray room, I would make sure I have help. So this is one thing I see technicians try to do. Please do not be a hero. There are very, very few situations where we should be doing treatments on our own. So x-rays, IV catheters, you can do it. You are a badass and I believe in you. However, it is not good for the patient's stress. So if you have a patient and the doctor's like, I absolutely need chest films. And from the doctor's perspective, we cannot move forward until I can tell the owner why this patient can't breathe, right? And so they want to get that diagnostic as soon as possible. But as a technician, you need to say, I don't want to kill this pet in x-ray. However, they say there is always a little bit of an impasse. So we compromise oxygen in the room, 2 people going very slow, being very cautious. If that patient shows any signs of declining or getting worse, we abort. We put the patient in oxygen, we take a break, we update the doctor. I just tried to do x-rays. I got 1 lateral x-ray. This patient decompensated. Again, I think we need to take a break. Maybe we can do some sedation. I am really worried I'm going to kill this patient. So still trying to get the x-rays, still trying to get the doctor and the client what they need, but going slow and trying to compromise on that is what I would do. So sometimes it's not always a yes or no, but it's a, okay, well, I am going to take 3 hours to do this to keep this patient alive. And usually as long as we're showing a little progress and a little bit of compromise, most of the humans in the room are okay. And then if it truly is an issue in patient care and that doctor's just being a jerk, then it's a bigger conversation. So observation and changes in mentation. So this is, you guys have all seen this, where like the owner comes to visit the cat and it's purring and they're like, oh, she's purring, she must be feeling better. And you're like, no, it's actually really bad. So inappropriate or persistent vocalization or purring. Inappropriate meaning the dog is in the corner of the cage barking, or the cat is purring and it's laterally recumbent. Like those types of things are inappropriate mental status. A patient who should be up and about and alert is not up and about and alert. That is a sign of decompensation. If you notice, I was just in with that patient and we did vitals and we walked outside and the patient seemed great. And now it's laying down. Now when I go in the cage, it's slow to get up, or it's reluctant to get up, or it's showing me that it's more obtunded or lethargic. That is an absolute emergency. Something has changed in that patient that's pretty drastic, and we need to recheck vitals immediately. And usually what you'll find is decreased respiratory rate, decreased heart rate, and possibly decreased blood pressure in these guys because they are decompensating.
Erica,
Yes.
I just, a side note, like as triage, When an owner tells you that their animal's normally super reactive or super aggressive or doesn't like people or doesn't, and they're like just laying there and like letting you pet them and whatever. When I train, I tell people if an owner tells you their pet is usually one behavior and it's displaying completely different, mentation is really important.
Yeah, yeah, and that is a really good point because they know their pet more than you, and they're always gonna rally when they come into the hospital. Or most of the time, they're gonna rally when they come into the hospital, so it's always important to watch out for that, and then owners always get super nervous about like, oh my gosh, I'm coming to the ER and I'm spending $200 and I might not need to. And so you will always hear them say, he looked like crap at home. I was really concerned. He was really dumpy. And then he comes in and he seems fine. Please reassure the owners, if he was dumpy at home, like he's going to get a little adrenaline boost. He's going for a car ride. He's meeting new people. He's super nervous. And especially dogs are fleasers, right?
Yep.
I see this when Dr. Brandt and I go to do euthanasia as general goodbyes. Like people will say, my dog has cancer. My dog has been doing awful for weeks. And then you guys come and ring the doorbell and all of a sudden he seems fine. And then they get nervous about, did I make the wrong decision? But how that pet is acting when it's resting in a comfortable situation is probably its true mentation. The patients that we get most worried about is the ones that cannot rally. Who cannot rally their mentation. So like if they get so obtunded and so lethargic that they don't get bright when you come in the room, those are the ones that are going to potentially arrest quickly. And so we need to, but that is a very good point. So listen to those owners. Yes, Brookie.
I was like, I just want to share another example of mentation and how critical that could be. Was working ER, a boxer came in that was having bleeding after dental extractions. Totally normal dental, no crazy extractions, but was just having all this bleeding from his gums. And so when he comes in, he's, relatively bright. PCV was 45. And so I'm just sitting there with him. It was brand new batch of baby interns. And they're in the room talking to the owner. And for like, after about 10 minutes, I'm like, you're just like, why'd you get dumpy all of a sudden? And nothing else had changed. He was still bleeding the amount he was bleeding when he walked in, nothing crazy increased. And so I'm like, I'm gonna recheck your PCV. It was 20.
Oh, gee.
It had dropped 25% in 10 minutes. And within another 10 minutes, I had that dog in the ICU with Dr. Brandt, and he was crashing as I'm slamming blood into him. Without that little mentation change and like, maybe I need to check that PCV because what else would it be that caused that really, And it was critically impactful. Like he probably would have died without just noticing that one little thing.
Right.
Yeah.
Yeah. And it's amazing. Like everybody's had it happen where you think you're taking care of a patient, they seem fine all night, and then you go to check on them 4 hours later and they're dead in the cage. Like those types of things unfortunately happen because we don't pick up on those mental changes. But if you're not getting enough oxygen to your brain, you will not respond appropriately mentally. And so that is shock. That is the definition of shock. Not enough oxygen to your tissues, not enough oxygen to your brain. And that's one of the first indications we get. So it's really important that we look for it, and we don't always talk about it. Like TPR, there's no mentation in there.
Yeah. Well, and it had nothing to do with him bleeding from his gums. It just happened that he unknowingly got into rat bait for his dental.
Oh,
That's why he was bleeding. He was bleeding elsewhere, because that didn't drop like that 25% didn't just disappear out of nowhere in 10 minutes.
Right. Right. And you're like, this dog is fine. He just had a dental.
Yeah.
Yeah. Okay, cardiovascular system. So tips on the cardiovascular system. This system can be somewhat intimidating because it includes blood pressure and ECG. The thing that I'm going to tell you as technicians, do I need you to be able to look at an ECG and diagnose the arrhythmia and know how to treat it? No, I don't. If you get to that point in your career where you are that technician that's like, this is a whatever, morbus to a arrhythmia, and this is what we use to treat it, and I'm going to drop this drug while I'm talking to the doctor, that's amazing. And I hope you all get there. However, your job as a technician is to be like, something has changed that doesn't look normal, and I need to tell someone about it. right? So when you are learning ECGs, when you're looking at ECGs, look at normal ECGs, and then you will start picking up abnormalities. And your job is absolutely not to second guess yourself, is not to get nervous, not take your ego out of it and be like, so this looks different. And I'm not sure that this is okay. And so get a doctor involved, get another technician involved, call Brookie over and say, I'm really scared to tell Dr. Brandt that I think this ECG looks weird. Can you look at it with me? But make sure that we are sounding the alarm. So how do we monitor the cardiovascular system? Perfusion, heart rate, mucous membrane CRT. You guys are really good at that. Checking pulses, checking volume status, checking blood pressure. So one thing that I want you to know when you're checking cardiovascular status is patients who are compensating. So if they are shocky, if they are painful, if something bad is happening in their lives, if their body is doing its job to keep them alive, they are usually tachycardic. They are compensating for whatever that is, and we have some time. Once that patient starts getting bradycardic, dumpy mentation, decreased respiration, these are the patients that are getting closer and closer to arresting. So bradycardia is scary. So these are those cats that come in and their heart rate is 120 to 140. These are the dogs that come in and they're somewhat obtunded and their heart rate is like 80, depending on the breed. Heart rate, like I said, is really hard because age of the pet, physical fitness of the pet, size of the pet, all tell a different story. But looking at that pet, if you have a really big dog and its heart rate is high, something bad is happening. If you have a really big dog and anything that's heart rate is really low, we are very concerned about that. A cat's normal resting heart rate, if you're sitting next to your cat, you're watching Netflix, everybody has snacks, everything is great. Your cat's resting heart rate can be 140. In the hospital, if your cat's heart rate is 140, I'm calling a 911, right? Like it is not okay because we are not a happy, safe environment for some of these pets. And so we're expecting certain things with these animals. But the biggest thing I want you to recognize, tachycardia, we probably have some time, we're compensating, we're painful. Bradycardia, this patient is getting closer to arrest and I need to do something sooner, faster, something is wrong. Doppler versus oscillometric. Know how to use a Doppler. A Doppler really is the gold standard. There are a lot of different places that you can get a Doppler blood pressure. The biggest thing that I see with technicians trying to get a blood pressure is they get so concerned about not being able to get one. If you're trying to get a Doppler on a patient who you are concerned is critical and obtunded, not getting a blood pressure is diagnostic, and you should tell your doctor that right away. Instead of spending 15, 20 minutes like, oh, I can't get a blood pressure on this patient, not getting a blood pressure is what you should be telling them, because that is the diagnostic. That is the reading. I cannot get a blood pressure on this patient. That is start fluid boluses. We'll try to get another one in 15 minutes. So that's probably the biggest thing I see with critical cases and with patient care is not being able to get a blood pressure and being nervous about saying, I can't get a blood pressure. The other thing is telling the doctor if the blood pressure has changed. And then the other thing is if you are doing a blood pressure on a patient and it's like 40 and it's dragging you around the room, it's probably not 40. So really looking at, is my technique off? Is there something wrong? Making sure you're getting help. Because the other thing I see is technicians struggling with getting a blood pressure on a patient and not just asking for help and getting it real quick. You're not going to get an accurate blood pressure. You're going to be really frustrated, those types of things. But if you're not getting one, it's probably diagnostic, especially if the patient is critical or obtunded. If the patient is dragging you around the room and been stable and then you record a blood pressure of 50, we might want to rethink that. But just really critically thinking about what number am I getting? Does it match with this patient? And should I be doing something about it sooner than later? This is how we actually measure for a blood pressure cuff. I think probably 90% of the time, if we get false readings or if technicians struggle with Doppler blood pressure, it's because our cuff is wrong. So this is how we should be measuring. I do blood pressures on the bottom of the pad. I know a lot of people do them on the top. Honestly, it doesn't really matter as long as you're doing consistently. So the biggest thing with blood pressure is if I do a front left leg with a number 5 cuff, I need to write that down. Because if Brooke comes and does one on the back right leg with a number 3 cuff, and they're slightly different, we should expect that. But if she does the same blood pressure, left front leg with a number 5 cuff, and she gets something that's 20 millimeters of mercury different, then we're concerned about that patient, right? And so we should write down what cuff, what leg, and how we were doing it. So we're doing it consistently because we're watching for trends, right? Temperature is important, maybe not in the beginning. Do not kill your patient by trying to get his temperature if it is stressed out, has a respiratory issue. However, temperature is important. In my clinical experience, patients that are typically hyperthermic or hot, it's because they were post-op and we left the blood or the Bair Hugger on too long, or they're stressed, or they have an infection, or it can be a true heat stroke, but not very often, unless they're coming in for that. Most of the time, shocky critical cases are hypothermic, and this happens with shock or decreased blood circulation. These patients that are hypothermic, especially if they're post-op, or we're trying to fluid resuscitate them before warming them up, have an increased risk of volume overload. We also have a decrease in coagulation tendencies for these patients. Abnormal cardiac, renal, hepatic, and immune function. So being hypothermic is an issue. We need to make sure patients are warmed up and taken care of. And most of this comes from anesthesia. Most patients that come in through the ER haven't been cold that long, but they're probably shocky and we need to warm them up when we're giving them fluids. And then make sure we avoid burning patients. So Bair Huggers, fluid warmers, all of those types of things, but be careful with fluid bags that are warmed up and those types of things. But the biggest thing is if they're shocky and we're fluid resuscitating them, making sure that we're warming them at the same time. And then the other thing is making sure we truly need a temperature. One of the things that I see quite often is we continue to take temperatures on patients who have been stable for days every 4 hours. It's probably not necessary. So just talk to your doctor about like, do I really have to keep taking this dog's temperature for 4 days after it's been normal every 4 hours? Fluid therapy, we kind of already talked about this a little bit, but when you are initialing that fluid therapy line, when you are saying this patient is getting 20 mils of fluids, you really have to ensure that the right fluids are connected to that patient, that the fluid bag is actually, fluids are leaving the fluid bag, that the pump is working appropriately, that the line is hooked up to the patient, that we're not giving fluids to the blanket, and this patient is being taken care of. We're looking for fat foot. We're making sure the catheter is actually in the vessel and that we don't have something like phlebitis or irritation in that vessel. We need to make sure that the catheter site is clean. We need to make sure that the tape isn't wet or anything weird like that. And then we also have to check this patient's hydration status. If you have a patient, fluid therapy is a treatment. And this is one of the most messed up treatments that we have in veterinary medicine because we don't often take it seriously because it seems very benign to us. But if you are watching a patient, monitoring a patient on fluids, it is also your job to make sure they are not getting volume overloaded or they are not staying dehydrated. So if they are vomiting, if they are diuresing in some way, and we are giving them fluids, but they're still dehydrated. So they're tacky, they have skin tenting, they still seem pretty dehydrated. We need to let the doctor know that. If they start coughing, if they seem really jiggly, if they have fluid coming out of their nose, anything like that, we need to let the doctor know that this patient might be fluid overloaded and we need to back down on their fluids. If they are on fluids and they're peeing every hour, they are getting probably a little more fluids than what they need to get, and we might be able to back them down. So this is the responsibility of saying 20 mils per hour when you mark that box. Fluid therapy is a drug and we should take it seriously. And these are all the things involved with that treatment. The other mistake that we often make in veterinary medicine is medication mistakes. So this is probably, and fluid therapy might honestly be the second biggest mistake that we see, and medication mistakes are the most devastating and probably the most frequent mistake we make. And it's all the way from the front to the back, from making the prescription to administering the prescription to sending it home with the client. We're sending home empty bottles. We're sending home bottles with the wrong pills in them. We are giving pets the wrong pills. We're giving them the wrong dose. We're giving it the wrong route. So there are a lot of things that we are messing up. Our CRIs are off. Our dilutions are off. So there's a lot involved with giving medications, and we have to take it very seriously. When you give the same drugs day after day after day, it is, and not have any issues, it is very easy in your human brain to not take it as seriously anymore. You haven't seen any ill effects. This patient gets this drug, everything's always fine. Sometimes we have to step back and remember that there can be serious medical mistakes and we need to be careful. I have worked with some amazing technicians, rock star, awesome technicians, and seen them make awful medical mistakes because they had ego and they didn't have their calculations double checked, or they just automatically went on what the treatment said and they didn't double check it. I mean, there are a lot of reasons why we take these. One thing that I've seen that happen quite often is if you are using software to calculate medications, people will put weights in and they don't hit enter and all of these types of things. So I almost always, I would say probably 99% of the time, have someone double check my drugs. Just because I've seen this so many times and seen some really great technicians ruin their careers or ruin their confidence over medication mistakes when we could have just had something double checked. Ask your doctor if you have a question. If they write something down and you're like, this seems like a lot. If you draw something up and something, the hair on the back of your neck stands up and you're like, this does not seem right, ask the question, do the math again, double, triple check, make sure that you are checking labels. I came in one day to an ER shift and the team said, none of our cases are going to sleep today. Our dextometer is not working. So I went over and I looked at the dextometer and they had kept the bottles in the boxes and they had switched. So the dextometer was in the antecedent box and the antecedent was in the dextometer box. And so they thought they were giving dextometer all day when they were actually giving these patients doses of antecedent. And I said, absolutely, your patients are not going to sleep today. And not only are they not going to sleep, but now they are not going to go to sleep for quite a while because now they have antecedent on board. So just little things like that. Like, these are amazing technicians that I would totally trust 100% with all of my fur babies. And they just made an error in, you know, they made a bad choice and they didn't double check something. I have seen really great technicians be tired, be overwhelmed. Verbal orders. Do not take verbal orders. We need to stand up against that. If you have a doctor who stands in the middle of the room and gives you verbal orders, give them a sticky note, give them something, but refuse to do medications based on verbal orders. I would say probably 75% of the medications mistakes that I have seen that I have made have been because I thought I heard the doctor tell me to give something and I heard it wrong, right? Or I heard it for the wrong patient. So do verbal orders get us in trouble every time? I cannot do verbal orders. I have to write them down for the doctor, ask the doctor to write them down. Do not do medication off of verbal orders. Make sure we're checking the labels. Make sure we're checking the drugs. Sometimes it happens where we get a drug in the hospital and it's a totally different dose than we've been using for the last 10 years. And I'm like, I know hydromorphine is 2 mg per ml. And then we get hydromorphine that's 10 mg per ml. And I'm like, I didn't even know this existed. And so in my technician brain, I'm like, I don't even have to look at this label anymore. I've been giving this drug for 10 years and I don't look at the label. And then I find out later that it's 10 mg per ml, not 2 mg per ml, right? So I read the label every single time. People probably think that I'm an idiot, but I will not, I refuse to make some of these mistakes. I check the label, I double check. I love SmartFlow now because it actually does the calculations for us. I do the math. I look at the label, I put it in SmartFlow and make sure SmartFlow and I agree that that is the math. So that's my double checking. Sometimes if I'm really tired and I'm like, this doesn't seem right, I will absolutely have someone check me because I don't want to compromise patient care and I don't want to be that technician that gets fired after 20 years because I overdosed a patient or hurt a patient. Down patient care. So one of the things that we have to think about is what does this patient need from me if it can't do things on its own? This is for cats as well. Not being able to get up, we need to move their limbs, we need to brush their hair, we need to make sure that they can use the bathroom, we need to make sure that they have urinary catheters placed, we need to rotate them from one side to the other. Down patients are pretty hard to deal with. We should still be getting them outside. So if they can go, if they're not on a ventilator, in oxygen, if we can get them outside, it's good for their morale and good for getting them to eat and those types of things. So getting them up and getting them moving. This is also important for cats. So this is actually a little kitty that I thought had died under anesthesia. And I came in the next day and I was doing some work in the office and the technicians brought her to me and said, hey, she needs to have some encouragement to eat. So we're going to let her wander around your office. So she hung out in my office for a couple of hours and she ended up eating and doing really well. Which was great for my morale too, because I was pretty sure that she had died. So that was good. So nutrition, feeding pets in the hospital is not always easy. And I am definitely the ER technician that likes to be in triage. I like to be doing procedures. Working with hospitalized patients and trying to get them to eat is not my superpower. I'm not good at it. We used to have a technician that we worked with and her name was Brandy and she was amazing, but she was one of those technicians that was like, I want to be with the case and I want to spend hours trying to get them to eat and walking them and fluffing up their hair and making big beds. And I was not that technician and she would come in every single time after I'd been struggling with a pet for 8, 10, 12 hours. And she'd be like, I'm going to make it this beautiful meal. And she would get it to eat every time. But nutrition is so, so important for our patients. We really need to try to be good at this. And I did try, but I was never really good at getting patients to eat. So one of the things that we need to ask is how often do these patients need to eat? If I approach a cage and the patient says, no, thank you, I don't want to eat right now, but it's really important that that patient eats, I might not want to wait a full 4 hours before I try again. However, if this is a patient that has been in the hospital, post-op case, somewhat stable case, we're just waiting for the owners to be a little more comfortable, he's been eating pretty consistently, that patient might not need to eat a full meal every 4 hours. So maybe we can switch to Q6, maybe we can switch to Q12. So really talking to the doctors about, do I really need to feed this guy every 4 hours or can I feed him smaller meals? Yes.
Can you take into account like their feeding habits at home?
Yes.
Like when they're hospitalized with us for days. I mean, if the pet's only used to eating twice a day and we're trying to feed it.
Right. We can definitely take that into account. Sometimes it's hard to manage that. Like if all of your patients have different feeding schedules, it might be a little bit weird, but definitely like most pets eat twice a day at home. And so for us to try to feed them every 4 hours and then we get worried, we're like, oh my gosh, George didn't eat.
Yeah.
It's like, we have been feeding him for 3 days, every 4 hours.
Like when your
That's
grandma
huge.
tries to feed.
Finally, even the biggest dog or even the like most piglet dog is finally going to be like, I stop. Just no, just can't take anymore. I cannot. Like, thank you so much. This has been the best experience of my life, but I am just not going to eat that. Like, I have had enough. And so just really paying attention to like how much this patient should eat. The other thing that we have to watch for is nauseous patients or food aversion. If you have a cat who's nauseous, who's not eating, that's NPO, whatever, if we warm up some wet food and make it real stinky and really nice and we're feeding their neighbor, we might actually induce some nausea in the patient next door. So really being aware of food aversion, nausea. If that patient didn't really want to eat, but I feel like I can get them outside and walk them and maybe encourage them in a couple hours, try that. If we're just feeding them too much, if they're nauseous and vomiting, if they get really nauseous and start drooling when I'm trying to feed them, we need to be talking to the doctor about anti-nausea medication. Maybe they're painful and we need to talk about pain medication. So all of these things are really important to get the patient out of the cage and see if they'll eat outside of the cage, including cats. Take them an x-ray, take them in another room and see if they'll eat not in their cage. Cats do not like to sleep. they typically don't even like to drink next to their food bowl. And so getting them out, getting them moving, getting them in an area where they can stand up and approach their food that's not right next to their litter box sometimes will encourage them to eat. And some kitties like kibble. It doesn't make sense to me. I want to warm up their food and give them this beautiful gourmet baby food, whatever it is, and they just want kibble. So trying different types of food is important too. And then urination and defecation, we talked about this a little bit. One of the things that I see that makes me a little bit crazy is when we don't take into account the cleanliness of the hospital environment. So sometimes I see fluid lines left on the floor. I see fluid collection or urine collection bags just left on the floor. So I want at least a chuck underneath them, a clean environment for that type of treatment for the patient. We should be making sure that the patients are producing 1 to 2 mils per kg per hour of urine. If they haven't urinated for a while, do they have a big full bladder? Are they holding it? Do they have a urinary catheter in and we're getting very low quantities? Have they not urinated and they don't have a big bladder? Like these are all concerns that we need to be thinking about. A patient not defecating, I guess, is less of a concern for me, but I'm more interested in if they're not urinating, why are they not urinating and how long has it been? That's definitely a concern, especially if a patient is on fluid therapy. If they are on any type of pain medication, they might not defecate for a while. It's probably something we should bring up with the doctors just so they're aware of it. Diarrhea is also something we want to bring up. Yes.
I have a question. So what do we do in cases with like a big dog that we take outside that they will not be on a leash? It's like my sister's dog will not be if she's on a leash.
Right, and they're like, that's the thing, is like, if people have a yard, so they take their dog to the backyard and they let them out, and now they have this creepy girl that's walking them outside to let me, and they're like, excuse me, I'm not gonna pee while you're standing there, like, it's not gonna happen, and so, with those patients, or if the owner tells me, like, he will not go to the bathroom on a leash, what I try to do is connect multiple leashes. So sometimes if you have 2 or 3 leashes and give them just a little more space, sometimes they'll do okay. Eventually they will go, but they'll hold it for a little while, or they'll go in the cage when you're not watching. So if you notice that if you have a patient who seems kind of shy outside or like a complete idiot on a leash, it's probably because they're not used to it. And they'll usually either go in the cage when they think no one's watching or give them a little bit longer leash and they'll do better. So I'm definitely paranoid. I've lost a patient outside. So this used to be a car dealership called Cars USA. And we were in the other building and I walked a surgery patient outside. I can't even remember what happened to the thing, but he was aggressive and he always tried to kill us. And I got brave and walked him outside and he got away from me and he came over to Cars USA and crawled underneath some car and I'm out there in the dark by myself in the middle of the night trying to get this lunging dog out from underneath this car that just had a surgery. And so now I will never take a dog off a leash and I always make sure I have multiple leashes. So I will never recommend just turning them loose in the yard and hoping they go because I would never want you to have that experience, but attaching multiple leashes, sometimes you could make them think that you're not being a creeper and they don't. So, patient comfort. So this is a beautiful picture with the ugliest towel we've probably ever had in the hospital. But the reason why that I have it up there and the reason why I love this picture so much is I love to cover the cages. And I will always have a technician that says, how can you tell me that you're watching this patient when the cage is all covered? And honestly, it doesn't have to be the entire cage door, but giving that patient a little bit of privacy. We love our patients. Sometimes they don't love being here. And so giving them a little privacy, giving them a little space, giving them a little safety is important. So just a little bit of some privacy, a box they can hide in. If they're sleeping in the litter box, put another box in there, cover the cage. They are trying to tell you that they need something to hide behind. And that's why they're in the litter box, because they have nothing else in that cage to get behind and hunker down in. So they sit in the toilet because that's the only safe place they have. So covering up the cage. The other thing that's very important is I used to work with a technician and the first thing she did when she came in was clean all the cages and start them. And she was wonderful and she really cared about her patients. But one of the things that's really hard is if that cat or if that dog has been sitting in that cage and they finally made peace with it, this is my space, I'm safe in my space, and someone comes in and takes away all of that, and now it smells like cleaning supplies and it smells like all new towels. Now it's a whole new space, and now I'm uncomfortable again. So unless the cage is truly soiled, where like that towel needs to come out, try to keep as much familiar as possible. So be really careful about the cage needs to be clean, but it doesn't need to be like scoured and disinfected every single time. And don't take all the bedding out just because one is messed up. Maybe just take out the one that's soiled. Sleep is also very important. So if you have some time in the evening during your shift, turn the lights down, it's quiet time. We don't do any treatments unless they're necessary. If that patient is sleeping and they're only due for vitals and they're completely stable and you have time, let them sleep, let them rest, keep an eye on them, observe them, absolutely. And if they're critical and those vitals are critical, do those vitals. But if that patient is able to sleep in our hospital, gets comfortable enough that they're resting, think about letting them rest. And then the other thing that I see with cages and bedding and comfort is we all want to give them snuggly blankets. If that puppy came in because it has a foreign body, he might not get a blanket. Like, you might be in trouble and you might not get a blanket. So make sure they're not eating their bedding or eating their catheters, those types of things. So cat tips. Cats like it quiet and dim. They like to hide. So anytime we can give them a box or something to hide behind, let them come out to you. I have a video that one of the cat ladies shared with me, and it's a video camera inside of a kennel, and it has a technician coming in like this to like it was grabbing a cat. And humans make a shushing noise to comfort, like we're like, shh. What does that sound like to cats? It's a hiss. And so we're like, shh. And the cat on the other side of that is like, oh, hell no. Like, I do not want it. So letting cats come to you, taking the top off the carriers, letting them come out of the carrier. When you open the cage door, instead of just going at it, I'm going to get vitals, I'm going in, pull the patient out, doing the vitals. Talk to that baby first. Introduce yourself to that baby first. This was like some talk show a long time ago, but I watched a woman who was a neurologist who had a stroke. And she came on and she talked about her experience in the hospital as a doctor and after having a stroke. And so she said she had a stroke. She didn't really remember anyone. So she had some amnesia. She didn't really know where she was. And she said that she would pick up on the nurse's behavior. So like the nurses would come in and they'd be like, oh, your mom's going to come visit you. And she's like, I didn't know who mom was, but because the nurse was so excited and happy about it, I was excited and happy about it. So just the way the nurse was talking to me, like, oh, you're going to have a visitor. I was like, woohoo, good. And so she was very excited. And then she said she could tell by the nurse's approach if they were coming in to do something that they thought was kind and happy, like bringing me food or fluffing on my pillow or just coming in to say hello to me, versus the nurses that were coming in to do a treatment, especially if it was like drawing blood or something. And she's like, I could tell by the way they approached me if I should be fearful or not. And so that really made me think about the way that I approach patients. If I am very focused, if I'm stressed, if I'm like, I got to get in there and get these vitals done because I'm behind, do I approach that patient and not really look at that patient or make that patient feel comfortable? And I'm like, come here, I'm doing your vitals. And put the leash on you, walk you outside and just put you back in your cage versus like, I go in and I'm like, oh my gosh, you know, and I'm not good with the baby talk, but I will like, you know, at least take a moment and be like, hi, I'm here to take care of you. You know what I mean? Kind of a thing. So really how we approach the patient can make all that bit of a difference for them because they recognize it, right? They know. Canine tips, think about the patient. What are their name? That really helps center me, really knowing the pet's name instead of being like, this is a TPLO and, you know, this is a hemoabdomen that had a splenectomy, you know, that type of stuff. I'm like, what is his name? Because I want to start thinking about him as George the Great Dane that had a splenectomy and now he's nervous because he's a big baby and his mom snuggles with him every night. Like, that's what I want to start talking about instead of like, this is a hemoabdomen, these are the vitals that are due. I want to think more patient-oriented versus task-oriented.
So less clinical, I mean, clinical, obviously, but the
Right.
pet is a pet, not just.
Right, and it just helps me keep my mindset right as far as I'm there delivering patient care and not just checking the boxes. And I don't know if that works for everyone, and you might have things that you need to do a little bit different than me. I'm just trying to share how I keep it from becoming robotic, if that makes sense.
Yeah.
Aggressive or heavy patients should be on the bottom. You never want those aggressive patients up here where your neighbor is, attacking you from the face, all that types of stuff. Walking, exercise, getting these patients out, getting them in the sunshine, doing treatments in the sunshine. Sometimes I'll take a temperature outside. Sometimes I'll feel for pulses outside. Sometimes after they've pottied, I'll, watch their mentation. I'll finish my physical exam, get them out of the cage and really see how they're acting and see how they're doing. Are they sore? Are they stiff? Are they limping? And they weren't limping before, any of that stuff, really pay attention. Sometimes walking outside, we get a little impatient too, or we're like, I see a lot of texts on their phones. So the dog's going potty, we're kind of walking around scrolling on our phone and we're not watching to see, did they posture appropriately? Do they seem a little stiff? Are they limping? That kind of stuff. We get a lot of information being outside with them too. And then TLC, there's Brookie. So TLC, make sure that you don't only have to approach that patient if it has a treatment scheduled. If it's in the cage and it's looking at you and you make eye contact and you have a minute, go in and snuggle that baby. What I see technicians doing now is that we're sitting at the computer, we're socializing, which we should goof off a little bit. We should socialize a little bit. But like having discussions, that's kind of satisfying. But if you have a minute, don't sit down and scroll on your phone. Go back in and be like, how are you doing? And snuggle that baby a little bit, get to know that baby a little bit. It's good for you. It's just as good for you as it is for your patients. Make sure that we encourage owners to visit. I don't know if you've noticed the change in patients when they get to see their owners. That's a really big deal to them. And we have nothing to hide. We should have every owner in here. We should be like, come back and look what we're doing. We're taking such good care of your pet and 100 other ones. Like, come in and see what we have. Our house is a little bit messy, but we have nothing to hide. Please come see your pet. Let them feed them, let them, groom your patients. If cats have a messy face, wipe down their face, brush them, do whatever it takes to make them feel a little bit better. And then the last step is evaluation. So now that we've done our assessment, we've made the plan for the patient, we agree with all the treatments, we're getting through all the treatments, we're watching for all the extra stuff. Is it actually working? Do I feel like my patient has fluid overload? Are we concerned about my patient? Do we need to do something different? Make sure you're speaking up. Do I need to walk more often? Do we not need to do this as often? What's going on? So I know that a lot of you are thinking, this lady is crazy, and I definitely don't have time for all of that. And the reason why I go in and do vitals and get out is because I am so completely overwhelmed. And I hear you. I've had those nights, I've had those moments where I'm like, we just got to do vitals and move on. Or I will do my best to take care of this patient and I'll speak kindly and take a little bit of extra time outside or whatever, but I really got to move on. Make sure you're communicating, make sure you're asking for help. It is always, always, always about the patient. So let your ego go. Tell someone, hey, I know that we're all busy tonight. I'm really going to focus on these patients. If you have any time, can you please take George out? He really needs to go for a walk. Prioritize, triage the in-house cases, just like we would triage coming in from the ER. What treatments are going to make or break this patient's care? What treatments are going to make and break this patient's care? What patients need to go first? Ask questions, be prepared, be efficient, approach it with all of your stuff together, weigh them when you walk them, take the vitals outside when you're walking them, make sure you have your meds and your food ready to go, try to plan ahead a little bit and be as efficient as you can. It's better for the patient too. And then how to handle the quiet times. Get off of your phones. do some training, train each other, and then just get in the cage and snuggle your patients. Spend a little bit of extra time, that time that you don't get to spend when you're super busy. Go in and snuggle them, brush them. If you like to deep clean and stock, by all means, there's plenty of that to go around. Talk to each other about cases. There's tons of training material from our lovely CESs. If you know a technician who's struggling, say, hey, let's talk about this case. Let's talk about what's going on with this patient and why I'm concerned about this patient tonight. So there are so many good things that you can do besides being on your phone when it's quiet. And then that is all I have for you. 22 years of patient care, all done out in the lab. Does anybody have any questions?
I
Yes.
do. Last year and a half or so, I went to a CD here, talking about just general animal welfare. And one of the things, especially within a clinical environment that they were talking about is as far as taking care of their comfort, whatnot, is, clinical noise. And how if we are able to mitigate how much unnecessary pollution there is within the clinical environment, you know, us yelling across the room, or the emergency room is the single biggest clinical room in the entire hospital. It's a high traffic area. People are hollering, we're shutting cage doors, phones are ringing, monitoring equipment is going on. How much of that do you think is really affecting patient care?
I think it's a lot, right? Because like these, when you think about these pets every day, they're used to you and your family. And so if you, I mean, if you have a really rambunctious home, lots of kiddos, a lot of people in and out, maybe they're used to a little bit of that. But like the cage door, all of this is foreign sounds to them, and it's already scary. It's also not good for all of the humans either.
Right.
If you spend a 12-hour shift, especially if it's evening, you know, when your brain really wants to be resting, how much of that is really necessary? And so, you know, just having that open dialogue, if you have a technician who is a little more abrupt in their movements, so they're slamming pages versus closing them quietly. And then the other thing that I would recommend, which we used to do in the ER all the time, is we had quiet hours. And so at 2 a.m., when the clients kind of calmed down a little bit and we could turn down the lights and we had quiet time, you know, we really advocated for that. And so, you know, just having a discussion amongst your team and being like, I would really like to advocate for us and for the patients, like we have a quiet time. And, you know, we don't yell across the room, or we try, and I know we've tried to keep like phone calls up front and those types of things to keep everything in the back, but I think that's very important.
I've
That's
always,
something we always talk about, you know?
yeah, and I've always thought of it, if I am in this room and like overstimulated, 24 hours, everybody, like, you know, those patients
Well,
are.
honestly, I think that's the biggest thing that's been going unsaid is that, yes, we're focused on how it affects patient care, but it overstimulates your nursing team. It's hard to critically think. It's hard to multitask because it's such a diversion with having so much activity around you, so much. And like, we know those times that we are expected to be quiet, when we have a sedated patient on the table, when we have a family saying goodbye in the ER, you know, things like that. But to do it or not do it on a regular basis and just be mindful of the noise is really, really challenging. And that's the biggest reason why they made the doc in the box downstairs, is because these doctors cannot have phone calls in those cubicles that they had set up.
Oh, in the back.
That cause. And so I feel horrible because I am shushing my teammates all the time when we don't have a sedated patient or something. It's just unnecessary. And I'm trying to make sure that it is like patient care focused and not just, it's just noise. That's all it is. And it's hard working in such a high traffic area and try to keep it down. Just because of the foot traffic through there. And it's easy to holler across the room, then get out of your chair and walk 10 feet. Things like that. But the CE was talking about how noise pollution in the clinical environment slows everything down for the patient as well. So I didn't know if you have any tips other than continuing to try to keep people mindful?
Yeah, and I think people just don't realize it. Like if you're in a conversation, like sometimes you don't even realize how loud you're getting. If you're like giggling and having a good time, you're like, oh my gosh, I don't believe I happened to me this weekend. And you get kind of like excited. So I think just continuing to make people aware of it. But I don't think it's wrong too to like get everybody on board and talk about it and be like, let's have a quiet time. Like between this hour and this hour, we are going to be, you know, pretty quiet for the patients or, you know, just having, it's going to take some talking about, I guess is the biggest thing.
We all know I don't have a problem talking.
So, yeah. I agree with you.
Okay.
Anything else you guys want to talk about? Right, well, thank you for being in there with me. Thanks, Erica.
Thank you to everybody for attending on Teams. As I said in there, I will get this video edited and uploaded to the YouTube channel by next week. So feel free to share it with your peeps, or come back and watch it if you want to. And thank you for attending.
Bye.